Topic for discussion is about the thyroiditis. So, what is thyroiditis? It is nothing but a heterogeneous group of inflammatory disorder. It is involving the thyroid gland, and the etiology range from infectious to autoimmune origin. So, coming to classification, it has been classified into acute, subacute thyroiditis, which is also known as de Quernis or granulomatous thyroiditis, and autoimmune thyroiditis, that is Hashimoto's or Graves or silent thyroiditis. Another name for silent thyroiditis is postpartum thyroiditis. And we have another known as fibrosing thyroiditis, which is Riddle's thyroiditis comes under the fibrosing thyroiditis. And we have palpation thyroiditis and drug-induced thyroiditis like amiodarone and lithium. So coming to acute thyroiditis, it's a rare, serious bacterial inflammatory disorder of the thyroid, and the etiological agents are Streptococcus pyogenes, Streptococcus pneumonia, Pseudomonas aeruginosa, and in fungal infections like Candida and Pneumocystis jirovecii are the most common cause of acute thyroiditis. So, how thyroid become infected? So, infection of the thyroid occurs by either by hematogenous seedling from the distant foci, that there is some infection at a distant foci which is causing the abscess in the thyroid, or to the persistent thyroglossus which is frequently infected, and another is extension from the adjacent infected structures of the thyroid, or due to direct trauma. So, any of this leads to the abscess of, if left untreated, it leads to the neutrophilic abscess in the thyroid. So, for acute thyroiditis, histopathology does not play a much role. FNAC plays an important role in acute thyroiditis. So, on acute thyroiditis and FNAC, you can see the neutrophils infiltrate along with the thyroid cells. And the treatment for acute thyroiditis is by giving the antibiotics, okay, and treating the etiological agent. Suppose if it is due to fungal, then you are supposed to give the antifungal. If it is due to parasites, then it is supposed to give antiparasitic medications. Next is subacute or granulomatous thyroiditis. It is also known as de Quernis disease or giant cell thyroiditis. It is the most common cause of painful thyroiditis. It is followed by systemic viral infections like mumps, measles, adenovirus, or upper respiratory tract infections. Recently, it is most common cause of thyroiditis. It is after COVID SARS, COVID virus infection. And anything, whenever there is a viral infection, their antigens get deposited on the thyroid follicular cells. So therefore antibodies act against this thyroid antigens, and they cause the release, destruction of the thyroid follicular cells, and they cause a release of the thyroid hormones which are in gush. So first there will be hyperthyroidism, there will be followed by hypothyroidism, and there will be recovery. So clinical features are that there will be pain and thyroid enlargement will be there, and inflammation of the thyroid and hyperthyroidism are transient, and they can diminish within 2 to 6 weeks even if the patient is not treated. And nearly all patients will have low T3 and T4 levels and low serum THS levels during this phase. And however, how will you differentiate from the Graves disease of the thyroid? So here also microscopically you will see the granulomas, giant cells and lymphocytes. But in Graves disease there is an increased uptake of the radioactive iodine, whereas here the radioactive iodine uptake is diminished, and recovery generally 6 to 8 weeks, the normal function of the thyroid returns. So here in this picture you can see that they are granuloma formation with giant cells. Next, coming to the palpation thyroiditis, it is also known as multifocal granulomatous folliculitis. Okay, it occurs due to mechanical damage to the thyroid gland, especially due to minor trauma to the gland, or any physical examination of the gland during physical examination, or excessive palpation of the thyroid, or due to any especially most common cause is due to any surgery which is causing damage to the thyroid gland. Here also you will see that whenever there is a damage to the thyroid gland, there is a gush of hormones which are released into the blood. So first there will be transient hyperthyroidism, and later followed by the hypothyroidism. And here also you can see the granulomas. Only difference between de Quernis thyroiditis, where you can see the granulomas, and palpation thyroiditis is in de Quernis thyroiditis, the granulomas are formed within the follicles. That means they destroy the follicle, and within the follicle you can see the granulomas. Whereas in palpation thyroiditis, the granulomas are formed in between the follicles. And you can see extravasation of the colloid, which is additional feature of the palpation thyroiditis. And next is autoimmune thyroiditis, that is Graves' disease. It is also known as Basedow disease or diffuse toxic goiter on exophthalmic goiter. It is a type 2 hypersensitivity reaction which presents with thyrotoxicosic like symptoms, and like anxiety, palpation, weight loss, exophthalmos will be there. And here autoantibodies are produced against TSH receptors, and the most common autoantibody here is thyroid stimulating immunoglobulin, which is not absorbed in any other autoimmune diseases except Graves' disease. So here what will happen, the TSH receptor are not only present on the thyroid, but they are also present on the skin surface as well as ocular muscles. So whenever there is thyroid stimulating immunoglobulins are produced, they stimulate the thyroid gland, and also they cause inflammatory responses even in the skin as well as in the eye. So whenever there is an inflammatory response initiated by activated seizures, there will be increased glycosaminoglycans which are secreted by the fibroblasts, and there is an immune complex deposition in the skin which is leading to pretibial myxedema, and even in the eye which leading croptosis, diplopia and conjunctivitis. And here you can see and goiter like symptoms. Because of goiter like symptoms, because this hyperthyroidism state, the thyroid gland will be, there will be a diffuse enlargement of the thyroid gland which is causing compressive effects like hoarseness of the voice, dysphagia, and increased blood flow to the thyroid gland, which is known as the thyroid gland growth. So grossly you can see the thyroid gland enlarged one lobe of the thyroid gland. You can see here homogeneous reddish color and beefy appearance you can see, and you will not see any nodules like Hashimoto's thyroiditis. So microscopically you will see here hyperplastic thyroid nodules. What are hyperplastic thyroid nodules? They are nothing but they have a pseudopapillary infoldings. These are not true papillae. They don't have a prominent fibrovascular core as in papillary carcinoma of the thyroid. And you can also see scalloping of the colloid, and normally thyroid gland is lined by cuboidal, flat to cuboidal type of epithelium. Here as it's a hyperplastic change, you can see the follicular cells appears to be columnar because there is an increased secretion of the thyroid hormones. So you see this scalloping, active scalloping of the colloid, and even follicular cells will also appear to be columnar. Next we are coming to the postpartum type of thyroiditis. It is an autoimmune condition where thyroid gland becomes inflamed within the first year of the childbirth, miscarriage or abortion. It is often followed by the biphasic pattern. First there will be in first 1 to 3 months after delivery there will be hyperthyroid phase, and there will be later there will be hypothyroid phase. So it will last up to 12 months. Postpartum. So coming to pathogenesis, first there will be autoimmune destruction of the thyroid glands, and there will be damage to the thyroid follicles, and there will be lysis of the thyroglobulin stores, and there will be raised levels of T3 and T4 in the blood. So first there will be hyperthyroidism, which thyrotoxic symptoms which are common, mostly transient in nature, and there will be later stages after 1 to 3 months there is a depletion of thyroglobulin stores, because thyroglobulin helps in production of the T3 and T4 hormones and making of T3 T4 hormones, and there will depletion of the stores leads to decreased T4 and T3 levels, and also increased THS levels. So it is a hypothyroid state you can see, and again later stages there will be regeneration of the thyroid gland, and the thyroid gland grows to the normal stage. Next, how will you distinguish this postpartum thyroiditis from the Graves' disease? In postpartum thyroiditis, there are negative TSH receptor antibodies and low iodine, radioactive iodine uptake. Whereas in Graves' disease, there are positive TSH receptor antibodies, that is thyroid stimulating immunoglobulins, and there is a high radioactive iodine uptake. And in this PPT, that is postpartum thyroiditis, is always associated with a genetic or family history, and so always we are supposed